is on. Okay, on. Thank you so much. Well, good afternoon, according to Brussels time, because we have colleagues from several parts of the world. So thank you so much for coming to this fourth forum, international forum of the European Consortium for the Study of the Second Victim Phenomenon. Today and tomorrow, we have leaders of the research, leaders of the intervention to support professionals, and also very good friends that during these 2 days are describing approaches, results of research, and new challenge that we must address in the future. For me, it's a great pleasure to say thank you to all of them, and also to all of you for following our activities. And now it's my pleasure to introduce Professor Marius Zongenau from the Romania Public Health School. And Marius, thank you so much for all your work in this action. You have the floor.
Thank you so much, Professor Mira. Thank you, Jose. It's been a pleasure to speak in the opening of our fourth forum. As you have already mentioned, this is a great opportunity not only to hear from each other's work, but also to share experiences from our countries and from our various subfields of work dealing with patient safety, adverse events, medical errors, and second victims. As you know, as everyone knows, the event is structured in 2 days to take place, today, October 2nd, and tomorrow, October 3rd. And it features a wide range of professionals and experts in the field of patient safety and adverse events and second victims. And it is intended to be a place where not only we listen to presentations and best practices being exposed, but also where we would love to engage in some meaningful dialogue. From today, I will, in a couple of minutes, will have the pleasure to introduce the first speaker. But before we begin, I would also like to give a brief overview of today, of the inaugural day of the forum. We will have an inaugural conference in just a couple of minutes, delivered by Ms. Pernilla Gunter from Sweden, who serves as EUPSF president. Then we will have an overview of the work that has been achieved in the past period by all of the working groups of the ERNST cost action. And then we'll have a presentation delivered by Professor Ushiro from Japan, and also together with our colleague Ina Skrulovic from Israel. And then another presentation who will be delivered by our colleague Basha Kutriba from Poland. And then we will have a way of engaging in a conversation with young researchers and fellows describing their studies. And we will have a series of presentations from a couple of countries like Slovakia, Croatia, Serbia, and Ukraine. And we will resume today's presentations, today's meeting at 4:45 CET, and we will have, in the sense, Professor Massimiliano Panella, who will resume, who will be making an overview of the day and ending with concluding remarks. So I'm looking to see if Pernilla has connected, and I don't see her yet. So maybe we would need to wait just a little.
Not
I'm
yet.
not yet.
But not yet. Maybe in 5 minutes.
Yes, sure. I also just sent an email just to make sure that the link is there and it's perfectly working. So in Jose, I suggest that since we would need a couple of more minutes until she is connecting, maybe we just do tour de table since it's been quite a while since we haven't seen, and yeah, just take this time to I don't know, share anything that is new, relevant for us before we.
Yes, just in these 2 minutes, I try to explain that if any of you that are following in streaming this forum, if some of you are interested to receive a certification about this activity, because academic reasons, research, or other reasons, please be taken into account, because my colleague Alejandro is sending you during the forum several times a message explaining a link in which you can ask for a certification of this activity. So for the people that is viewing and following this forum through the YouTube, there is an opportunity to ask for a certification of this activity as an academic activity also. So it's possible for them. Alejandro, when you can send the information through the YouTube. So it's perfect for them to ask for this certification. And now I suppose that our first speaker is ready to be connected with us, maybe. There is not any other message. So I think all is right.
Okay.
Maybe.
I don't see her connected yet. I see that Paulo is connecting now. Welcome, Paulo.
Hello, Massimiliano.
Hi, hello. Good afternoon to you all.
Hello, Paulo, Massimiliano. My pleasure. Bohana.
Hi,
hello.
Hi, Paulo.
Hi,
Professor
Shiro.
Usiro, let me
Good to see you here.
Maximiliano Panella from Italy is one of our leaders of the working groups. He's working also in defensive medicine and other practice and some other studies about patient safety. Bohana is working in a hospital in Zagreb. He's also a professor at the University of Zagreb. Hello, Bohana. Ivana is working with Andrea. And Anatoly is from Ukraine and now is living in Norway. He's also a physician working on patient safety. And Pernilla Gunter, hello, good afternoon. It's my pleasure to meet you here. So thank you so much for your kind acceptation to participate in this international forum. Thank you so much. And let me introduce to Professor Usiro from Japan, Einaf, Professor Rurodisi from Israel, Professor Tela, Susanna Tela from Finland, Marius, that you know by some messages, Professor Sandra Butik from Malta, Professor Andrea Hekova from Slovakia, Professor Bohana Senevic from Croatia, Professor Paulo Sousa from Portugal, from Lisbon, and Professor Anatoly Goncharov is from Ukraine, Kiev, and now is living in Norway. So thank you so much on behalf of all of us for your participation in this forum. Marius, you have the floor. Thank you so much to all.
Yes, thank you so much, Professor Mira. Thank you so much, Jose, and indeed welcome, Pernilla, for this to this forum and as a speaker for the inaugural conference of the forum. I will make a short introduction of Ms. Pernilla Gunter before she will continue with her presentation. Ms. Pernilla Gunter is an experienced policymaker. She served as a member of the Swedish Swedish Parliament, also of the Nordic Council and chair of the Welfare Committee, and also from local and regional councils. She's a founder of Focus Patient, a digital and physical meeting place for life sciences and healthcare with a patient perspective. She serves as president of the European Patient Safety Foundation, as I have mentioned in the beginning, and was appointed by the European Commission as an expert in the Cancer Mission Board. She is a lifelong patient, as being heart transplanted 15 years ago and cancer survivor twice. Pernilla, we are so happy to have you with us. Your experience is so rich, and it will bring such a great contribution to our forum. As we have been discussing, we have more or less 30 minutes allocated to this inaugural conference. And as we agreed, we encourage that this is a lively conversation during your presentation. We have time for questions and answers, and I'm sure your presentation will generate this kind of lively debate. That being said, thank you again for being with us, and the floor is yours.
Thank you so much, and thank you for inviting me to this important forum and conference. And I think that everybody should know more about patient safety, actually. Thank you also for bringing the topic to more people, maybe who do not think about it, daily, but are affected by the fact that patients can we all be sometimes, of course, and to just highlight a few things about patient safety overall. I think everybody should be aware of that when they are visiting some kind of healthcare facility and so on. I would like to share some slides to just support what I would like to talk about. Let's see if I can share the screen in a proper way. Yes. So I often talk about the patient's rights as human rights. And I also support a lot of what I'm doing, both in the European Patient Safety Foundation as well as in my daily work also with the platform and meeting place Focus Patient in Sweden. The European Charter of Patients' Rights, as you know, the European Union cannot, don't have the right really to maybe take it as a legislation, but at least we can have it as a basic document to work from. And the article, or the right of these 14 rights, number 9 is the right to safety. And it says that each individual has the right to be free from harm caused by the poor functioning of health services, medical malpractice and errors, and the right of access to health services and treatments that meet high safety standards. And what does that mean, really? It continues by saying that to guarantee this right, hospitals and health services, that's one of the areas responsible, must continuously monitor risk factors and ensure that electronic medical devices are properly maintained and operators are properly trained. So it's both about, of course, the human factor and also the devices that we are using in healthcare. But it also says that all health professionals must be fully responsible for the safety of all phases and elements of a medical treatment. I think that is quite interesting because it doesn't mention the patient. The patient has also actually a responsibility to not, of course, to know the same things as a trained medical professional, but at least to be aware of the foundations of patient safety where you are. All health professionals must be fully responsible for the safety of all phases and elements of a medical treatment. And I think also that is quite interesting, because it means that no one has not the responsibility to check whatever it is that you are handling or managing in your job as a health professional. So you cannot just blame the doctor or the nurse or someone else, because there are so many people working in health, of course, as health professionals. So everybody has got their role to play in this. But when we look further on in the text, it's also about the medical doctors. They must be able to prevent the risk of errors by monitoring precedents and receive continuous training. And I wonder sometimes, do they really have the time? Do they really have the time or the money to be able to attend all these important training sessions that are offered by professional societies or other conferences like this today? Healthcare staff, and once again, it's all health professionals, I guess, that report existing risks to their superiors and or peers must be protected from possible adverse consequences. And that's also about health democracy in some way. Because if you see something that is not working, can be dangerous, and it's handled in the wrong way, you have to have the guts really to tell someone that you trust that this must be changed. It's not patient safe. And we can see that from an actual case in the UK, where it has been reported in the news about this nurse that was reported had been not treated the babies right in a ward, but doctors warned about her, and they were more or less obliged to say they were sorry and they were mistaken and so on. They were whistleblowers, but was not taken seriously. And we can see that in many cases all over the world, I think, that it's more difficult to be a whistleblower than it should be, because the patient safety must be upheld and have a status to really maintain a good health and health sector that really also build trust to people. If you don't trust healthcare, you don't want to go there. That's just as simple. And of course, to use the World Health Organization Global Patient Safety Plan and to highlight the Patient Safety Day that was in September 17th is a good way to really raise awareness, I think, about this. In the European Patient Safety Foundation, we have launched a campaign called Fighting Fatigue Together. And we are collaborating with a lot of organizations. Fatigue is a risk for both healthcare professionals and patients. That's one area that has really been acknowledged in several countries, that people, because there is a lack of healthcare workers, of course, people are working longer hours, and they really need to have their vacations or their weekends or a day off now and then to really have the strength to be a good healthcare worker and also feel that they are doing a safe job. This campaign started in already 2015 when trainee anesthetist from the UK lost his life while he was driving home after a night shift, and he was exhausted and unfortunately died. I think it was a starting point really to acknowledge the fact that this must be taken seriously. We need to have more, of course, healthcare workers and trained, educated, and really to see that this is an important job. And we need to have more people who are really thinking that this is a job for the future. And when we see all this that is happening, that, you know, many healthcare workers are leaving their jobs, both doctors, nurses, and other professionals. We need to change that really. And long working hours can really be a factor that people say nowadays that, okay, the quality of my life is more important than my work. I need to be more with my children or my hobbies or whatever it is. I don't care really about if this is an important job. I need to have also something else in my life beside work. And we need to really think that rethink maybe is a more proper word, about time and how we deal with time when we are employing people. This was a national campaign in the UK, and it has now become European. And I think all European organizations really have to work with this factor, that if this is something that is really crucial to attract people to work in healthcare, if people are just working and do not have time or the strength to really have something outside work, they need to rethink about the organization, the leadership, and also the working environment, of course. The campaign objectives is, of course, to reduce the negative impacts of healthcare staff fatigue. The well-being and safety is the most important, but it affects the patients. If you're not safe with the people who are treating you, and I talked about trust, it's really a thing for you as a patient to meet someone that you feel you have a confidence, you trust that people to taking care of you. And if you see someone who are really too tired to take care of you, and I have an example, it's very popular nowadays with storytelling, but I really do have an awful example, and I can share it with you. A patient came into the hospital, to the ER, and he had, well, this is quite unbelievable, but he had a toothpick in his pocket, and he was so exhausted when he came home in the evening, so he just fell asleep, and somehow the toothpick just came out of the pocket. It fell out of the pocket and into his arm when he was moving in his sleep. So he had to go to the ER in the morning to have it removed. It had already been pushed in too far, so he didn't dare to do it himself. And unfortunately, the doctor he met, because it was in the morning, he had been working almost, 24 hours. He did a mistake. He pushed it too far in the arm, instead of, pulling it out. So it really went from a quite simple thing to do to a very possible, serious infection and a surgery instead. So from something very, very, as it seemed to be easy to do, because of a small mistake, it could have been very, very serious. So just with that example, I think that we need to rethink about all of the organization for healthcare workers. The campaign is supported by a lot of organizations, and we do hope that we could also have more national, of course, initiatives that are working with this, because all of these organizations have their members in the different countries, and we see a great need of really focusing on the fatigue factor. This campaign actually won the European Health Leadership Award 2 weeks ago in Gastein at the European Health Forum. So we're quite proud in the European Patient Safety Foundation to see that it has also been acknowledged by other sectors in healthcare. We also would like to invite you who are listening today and other people and organizations around in Europe to a workshop for national fighting fatigue campaigns in November in Vienna. And it is also connected with our conference for patient safety the day after in November 17th. So I do encourage you all to be in touch with our Secretary General, Mirka, if you like to join us in our efforts to this. I thank you for your attention, and I would love to really discuss more in general about patient safety and what it means to keep healthcare workers strong and really to have more also opportunities to be trained in patient safety and how we can do it together, of course, as well. Thank you so much.
Thank you so much, Pernilla, for your exciting presentation, and congratulations for the award received in Gastein, and also thank you for sharing the news about the upcoming conference. As a matter of fact, I strongly encourage one of my colleagues. He already registered for the conference, and he will be in Vienna in November. And I'm looking forward for him to already come back and discuss about the conference. We have about 15 minutes for questions and discussion, and I will open the floor for questions. And as our colleagues and participants are thinking of questions, I will start with one, maybe a more general one. And looking at the topic that you have been speaking on, it's health professional safety, it's patient safety, and things are really complex because you cannot only look through one lens only, because they are multidimensional. But on the other hand, your experience is so diverse. I mean, having served as a policymaker, but you yourself as a patient and patient advocate. And my broad question is, what are some of your lessons? What did you learn in this process in being a patient, a policymaker, a patient advocate? How can we disentangle this complexity? Because oftentimes we've experienced that the debate is quite heated, you know, especially when we see these unfortunately dramatic cases of either health professionals or patients, and it's very difficult, you know, to try and, you know, refrain and have a cold head and say, okay, let's discuss. It's really complex. We cannot blame and you know, throw shame on one entity or the other. So I was just curious, what's your experience in that regard, and what can you share with us and the audience of the forum?
I think you need to have a strong system for handling patient safety. First of all, of course, some kind of legislation that really says that you need to have a standard of patient safety in your own country. That's the first and the most important thing, because you need to support your healthcare workers and the patients through something. And I think legislation is the most powerful tool you can have to really set the standard also for that. And of course, what do you have the right to expect as a patient? I don't think, as I mentioned in my short speech, that everyone is aware about the fact that you as a patient really have to take care also of what you see and what you learn yourself when you're in some kind of healthcare facility. I think it's so stressful sometimes, because when I'm at hospital myself, I can see a lot of signs. You need to wash your hands. You need to have, well, it's restrictions about that and that. And then you can see healthcare workers are not taking care of that in that perspective that you expect them to do. I mean, during COVID, everybody should cover their mouths and really wash their hands and so on. And you should not be, it should not be needed to have all these signs, or it should be just, something that you just know. But you need to learn. And I think that it's not popular. I mean, talking about being a whistleblower, but it's not popular if you as a patient really mention to someone who's working as a healthcare professional that you see something that it's not correctly done. You are afraid of mentioning something because you are afraid to be punished, to not have the right treatment. And just to have that lack of confidence is really something that is a problem sometimes in all society, I think, because we need to really learn from each other and should not be afraid to tell someone it's right or wrong. So both from a patient or citizen's perspective, you need to be observant. But as a former legislator and former policymaker, I think the improvement of patient safety legislation in all countries is really, really something that everybody have to join forces to improve. I can also say that I'm always, when I'm at hospitals or visiting my doctor, it's a study visit.
Mm-hmm. Yes, indeed. And you are so right when you're speaking about this in a way power relation between patients on the one hand and healthcare professionals on the other hand, and indeed that makes it the more complicated in these situations. Professor Mira raised his hand. Jose?
Well, thank you so much for your words and your fruitful suggestions. I feel positive invite of the European Foundation that you are the leader, because you are sharing perspective and work from many different point of views, and also involving patients, professionals, academia, and so on. So I think is one of our targets, specifically in the working group number 1, is how to involve policymakers and other stakeholders for a better understanding of the meaning of the second victim phenomenon and its impact on the outcomes. So it's one of our targets, is on our objectives, but at the same time, it's very hard for us to involve policymakers. And maybe I would like to know from you some suggestions, some good experiences, some good practice, some minor ideas, but at the end are very useful to get our targets. So I appreciate very much some suggestions of some other ideas, because your expertise is higher in this direction. And maybe we have the opportunity to learn about your experience. Thank you.
Thank you so much. Well, I'd like to develop my answer in a few different areas. I think, first of all, if you have established a system for patient safety in your country, it is supposed to also reflect the different areas of, what is patients' rights or patient safety for the patients, for healthcare workers, for policymakers, for, well, everyone involved in this. And it also includes the right to have reimbursement if you are injured, some medical error or something like that. All have to be included in this work or this system, and to see how it's working together. So I think also, I mean, of course, the working environment for healthcare workers are also something that is not mentioned enough. How to avoid, of course, errors in healthcare, how to improve patient safety, according to what I was talking about, the patient safety, also that everybody need to know their roles in this. And if they are not continuously trained and educated in this within, I mean, I also work a lot with life science companies, and they are very, very much interested in how to improve patient safety, because they have their demands and their rules, and I think sometimes that legislators or policymakers, they are not aware of the fact that this must be included in all the things we do within healthcare. But not only that, it's also the social insurance system, it's the labor market system. So you have to have an overview of all these things to make it work. And when you can explain that to your parliamentarians or regional politicians and whoever there is who are responsible for healthcare and the healthcare workers situation, of course, I think you will succeed. You have to really show a picture of how it is, how things are, how they work together in a way. I hope it was some kind of clear answer. You see the puzzle.
I know that it's a very complex situation, and of course our countries have some similitudes, but also a lot of differences. So
Yeah.
maybe it's completely different in this part of the world than others, and between South, North, or Central Europe. And it's one of the challenges that we are trying to address. And really the experience that you described, because you, for example, the fatigue campaign is a clear example to involve different parts with a simple but a very clear idea with a clear target. So I would like to find similar ideas to introduce the problematic, the topic of the second victims in the area, because at the end, second victims, at least for me, is work for patient safety.
Indeed, it is, and I really think that we need to take care of people who are working with other human beings. It's really, really crucial for us all to have that confidence in healthcare, that you should be well treated, but also, as I said, to be a patient, it's also responsibility. It's not just to come there and think that you can have all the service in the world, and you know, you also need to to know more as a patient today than you could expect just maybe 10 or 20 years ago. There are so many more factors today to be aware about.
Thank you. Thank you so much.
Thank you so much for this this very interesting dialogue. And we still have, I don't know, 2 or 3 more minutes, and I guess we can fit in one more question from the audience if we still have any more questions.
Marius, sorry.
Yes, Professor Sousa, please.
Well, first of all, congratulations and thank you to Pernilla Gunter for this outstanding and very inspiring presentation, and congratulations for all the work you have been doing. I would like to know what kind of difficulties or barriers do you expect or foreseen regarding spreading this initiative to a multi-country, for instance, for Europe, as you mentioned?
The campaign, do you mean, or patient safety overall?
No, the campaign.
The campaign, well, first you have to admit that there is a problem. I mean, we need to fight fatigue. If you don't think it's a problem, then it certainly will be a barrier. So, of course, you need to acknowledge the fact that every country right now is suffering from, from this problem, and that we need to have more healthcare workers coming in the next years. We have lost so many during the pandemic and for other reasons for some years now. So if we should really, upgrade the healthcare professionals to have a status in society, really to work with people, to work within healthcare, you need also to bring this topic and to work with it. And that's just one of many, of course, but we need to do something. And I think this campaign is at least something that you can make people understand. And that's the most important thing right now. You need to understand what it's all about. And then you can bring it also over to other topics, of course, concerning the lack of the number of nurses or doctors or whatever it is, to really improve healthcare for us all.
Okay, thank you. If I understood, the main aim is to raise awareness regarding this topic. Okay, thank you very much. And thank you, Marius.
Sure, absolutely. And another question from Massimiliano. Massimiliano, please.
Thank you. Sorry, because I'm a bit, I'm getting old and I'm starting to be very low with the computer. Anyway, thank you so much for your presentation. I really appreciate it. Really, congratulations. My question is quite short, but I'm really interested about the timing. Following what Paolo said and also Jose, if we take as an example the action for the action that have been done for within Europe. Also, my God, sorry, I'm losing the. Wait. Okay, for the fatigue, take it as an example. I was wondering about the timing, because from the problem 2015 to today passed 8 years, so it's a long time just for increasing awareness, or what kind of outcome, intermediate outcomes can be achieved through such a long process.
Well, I think it started 2015 in the UK, and it has been more or less a national campaign, and then it was spread just last year to a more European campaign, and coordinated now by the European Patient Safety Foundation. So, and it has been highlighted more since the pandemic. It was really an increased need of talking about fatigue and how to fight the fatigue within the healthcare workers' societies of all kind. So I think, yes, 8 years seem like a long time, but it has not been, that active in all Europe as it is coming right now, and we are so happy that more and more organizations are really joining us in this now, because we can really see a need for a number of activities in this area, of course. As I said, to increase the knowledge about the working environments for healthcare workers.
Thank you so much.
Thank you.
Thank you so much for that. Thank you for your presentation, Pernilla, again, and for the questions and for the discussion. I will have to put an end to this inaugural conference here. Thank you so much. But we continue with the program today, and I'm giving the word to Susanna Tella, who will take over for the next section of the forum. Susanna, you have the floor.
Many thanks, Marius, and many thanks for Pernilla for your excellent presentation and for your important work that you are doing. So, but now we will have an overview of the ERNST, the Second Victim Cost Action Working Group's work, what has been done. So I will just share my slides here. Just a minute. So now we are going to hear about the working groups. There are 4 working groups in this ERNST cost action, and I'm here now the chairperson, and I'm chief specialist in health and well-being innovations in Lappi University of Applied Sciences, and I'm coming from Finland. And the ERNST, like the other cost actions also in the European program, they are multidisciplinary research networks and working with the pan-European researchers, but also with companies and policymakers and healthcare professionals and also patient representatives. So it's really important in these working groups to have interdisciplinary and interconnected and collaborative work with multidisciplinary countries. And now we will hear from these 4 working groups that are, the first is network promotion, that is led by Professor Marius Ungureanu, and the second working group is review and description of the state of the art, led by Professor Massimiliano Panella and Professor Chris Van Hecht. And the working group 3 is making it happen, and that is led by Professor Paulo Sousa. And the 4th working group is facilitators and barriers, and that is led by Professor Einar Skrulovici and Professor Sandra Puttikiek. And now we will have Marius, we will hear about the summary and about the update of the activities and that are in process about the working group 1. So please, Marius.
Thank you, Susanna. So I'm switching the hat now from moderator to reporting on behalf of working group 1. And with regards to the work that we're doing in working group 1 on network promotion, one of the key things that we are now focusing on in this period has briefly been mentioned by Professor Josemira, and that has to do with involving the European level policymakers in the work that we're doing. And I will present briefly the rationale for doing that, and then a couple of the more concrete steps and actions that we are taking in that regard. As most of you know, if not everyone, the ERNST cost action will end in 2024. And so one of the questions that we will be asking ourselves is, what is the legacy of the cost action, what will out-survive the work, the tremendous work that has been done by the people involved in the cost action, by all of the working groups. And one of the responses, there are multiple responses, of course, but as far as we are concerned in working group one of the responses is that we need to do every effort to raise this issue of patient safety, adverse events, second victims at a European level. So our objective in this period is to increase awareness of this work among European level policymakers. In many meetings that we have had, we have seen what we achieved to do at national level, and how we've seen a lot of progress in the debates in many of the countries that we're representing. And so one of the logical steps, next steps, is to bring this debate at the European level. And why European level policymakers? Because despite the fact that, as we know, for instance, at the level of the European Union, it's every member state's mandate to regulate these issues, there are still lots of things that can be done at the European level. And when we are saying European level policymakers, what we're really thinking of is, for instance, professional associations, be it doctors associations or nurses associations. We're also speaking about structures within the European Commission, whether we're speaking about Directors General of Health or Employment and other Directors General. We're speaking about European Union agencies, such as, for instance, the Agency on Occupational Safety and Health. We are also speaking about patient organizations. Patients are really at the core of the discussion, and so engaging umbrella patient organizations at European level is something which is really important. And last but not least, we need to also think of political decision makers, because in the end it is in their hands to bring policies and regulations in this field. And so what we have started doing is to prepare high-level discussion on the topic of patient safety, adverse events, second victims, gathering the categories of entities and representatives of European level policymakers relevant for our topic, as I've described so far. And what we have managed to do so far is to preliminarily have an agreement for such a high-level event to be organized in Brussels either this autumn or latest beginning of next year. And another thing that is relevant to mention, and then I'll come to a close, Susanna, is the fact that in this work we are using using as a tool the ERNST cost action policy statement, which summarizes the current status and also the challenges that we see ahead, and not only the challenges but also the solutions. So now, as I'm coming to a close, I want to in a way close the circle, because, as I said, the activities of the ERNST cost action will formally end in a couple of months, maybe close to a year. But we need to make sure that apart from what we're doing individually in our work and in our countries, there will be a legacy of this cost action, and things will be taken forward, and so that we can say that at the end of the project things are in a much improved state than they were when we began the cost action. So with regards to the specific meeting, as I said, we're now discussing with high-level policymakers, and we will be able to share the details as soon as we have them figured out. Susanna, giving the word back to you.
So many thanks, Marius, for the clear presentation about the working group 1. And it's really important what you said, that even that this ERNST will end, the work doesn't end. And now contacting the policymakers and publishing the statement of the ERNST about second victim and second victim phenomenon is really important work, and we can look forward for the great results. Thank you so much. And now we will turn, let me see. So Professor Massimiliano Panella, now you can present working group 2.
Thank you.
Summarize.
Thank you so much. I would like
you.
my screen because I have a couple of slides.
Okay, I will stop sharing. So
thank you. Okay.
Okay.
Okay, just 1 second. Okay. I think here we go. I think everybody.
Yes, we can see now.
Okay, thank you so much. Well, in our case, well, it's easier to find a legacy in the sense that for our task was more a task of research. So what's easier to make some deliverable that can stay. It's easier to have such kind of legacy for the future. Just in brief, to remember, we had 4 tasks. Task 1, to examine the current gap, current evidence regarding second victim and to find the gaps and possible to fill the gaps. Then to refine the concept, methodology, and new targets for research. So the future for the research of second victim, so second victims, and then task number 3, to assess the feasibility, acceptability of the design intervention technique. And that's for address such task, we performed a systematic review, and we had these 2 research questions. I will in a couple of seconds, I will go into the detail. And then we had task 4, that was what we can from the experience of other industries. So for that, we cannot use the review approach, but we use as output we prepare the report. We are preparing a report including the background, experience, intervention, and progress for each industry that we contacted. While we worked really as a team together with the colleague of the Belgium and with the whole team that worked on the 2 research questions. So the first question was what kind of impact of patient safety incident on the care professional can be identified, and we identify 3 possible elements, and then we go into the detail of the identification of the level of support for professional in the aftermath of the patient safety incident. Just in brief, we identified 5 levels for implementing support programs in the organization. And then also we identify possible preventive action based on evidence that should be taken to reduce the impact of the patient safety incident. Here you can find just a quick, just a screenshot of the publication. The review was published on the NCA Service Research this year, and just in brief, here you can find the 5 levels of the possible intervention. So the first level is the prevention, then self-care, then support by profession, by peers, and then structural support at different levels. But the point is that we are really happy about the results, because now we have a better understanding of a possible approach. Not to solve, because it's impossible at this level, at this stage, to solve the problem of the management of second victim, but at least, how to structure, how to give element to policymaker to better define possible strategies and framework to reduce the impact of patient safety incident, and so to reduce the second victim phenomenon. And this from literature, from medical literature, and then and this is over. So we are quite happy because we expected the time frame. So for that, this is a big hurrah. And then output 2 was what we can learn from other industries. We need a different, so basically was an analysis, the first step of the degree literature. Then we are going, because it's not finished yet. Then second step, scientific literature, and then going to the direct experience of possible providers. Of course, this is not exhaustive, because there are some limits, especially for the human experience, because we had to contact, and so this is a great work, really great teamwork with all the team, with all the colleagues from Europe. We were able to identify in different countries, different experience, and then to start to write a report. In the report, basically this is the structure. So for each industry, a quick introduction, the description of the methodology that was adopted in the industry, case studies, and lesson learned. And then some consideration about possible similarity and take-home message for the healthcare sector. This is a quick overview at the point that we are right now. So these are the industry that we identified and contacted. And really, again, I want to thank all the colleagues that worked in each country to go physically to the person. So, well, this was a huge book, really a huge book. And then this is these are the stage of development of the white book that we are not, well, maybe it's too much, but the booklet that we are preparing. So more or less, I think we are 50% of the work is completed, and we are really comfortable that we will be able to respect the timing of our task, that is 2024, the second quadrimester, but really, we are really comfortable to have a good, we cannot say the final draft, but a good semi-final draft by January, February at last, 2024. So, well, this is where we are right now. And really thank you to the colleague, because it was really a huge teamwork. Yeah.
Thank you so much, Massimiliano, for presenting this summary of your working group, and really great work thinking about the research that you have been doing, this systematic review about the second victim phenomenon, and understanding the different support levels of second victim, and also understanding then what we can learn from other industries. So I'm sure that also this working group will be excellent, have excellent results.
Thank you.
After we will end this cost action. But so many thanks, Massimiliano.
Oh, thank you.
We just need to go forward. I will now share the slides, and let's see. So, and then there will be Professor Paulo Sousa and Working Group 3.
Okay, thank you, Susanna. Can you please stop sharing? Okay,
okay.
I will ask you
to. Okay, I will stop
move.
sharing. So if you will.
Okay, yeah,
it's easier
that
maybe
will
for
allow
you.
me to share my presentation. Okay,
Okay,
thank you very much. Can you see my slides now?
Yes.
Let me see if now in a slideshow mode. Yes.
Well, actually, it is like we can see two slides. It's maybe
it's a presenter. It's a presenter presentation.
Yeah. Okay.
You need to switch. Over here.
No.
Okay. It's okay now?
Yes.
Then okay. So sorry for that. So good afternoon, everyone. It's a pleasure to be here. It's a pleasure for me to be here and participating in the fourth ERNST forum. And in the next 5 minutes, I will briefly explain the objectives and the activities carried out by our group and the upcoming steps for the working group 3, which I have the pleasure to coordinating. Working Group 3 has 41 members from 21 European countries, and we have been actively engaged in pursuing the following objectives over the past 3 years. First, to identify and describe good practices at the national, but also at the local levels regarding second victim programs and strategies. The second is to develop support and learning materials to disseminate knowledge and to support interventions in the healthcare setting. And the third one is to advance the identification of new and meaningful metrics to assess the impact of safety incidents on healthcare professionals. Since 2020, when this cost initiative started, we have organized 5 meetings, 2 of which were in person, the others were virtual due to the constraints resulting from the COVID-19 pandemic. The most recent meeting took place in June this year here in Lisbon. In these meetings, we presented and discussed the activities that the group had undertaken and also those that have been developing, as well ideas for the coming months. The deliverables from this working group include the development of 3 case studies, which served as support for the 2 training schools conducted. We also created a training manual containing introductory chapters on patient safety issues and explore the state-of-the-art and the best practices to consider when implementing a second victim support program. Additionally, we developed an online course on the topic, which is not limited to, but draws from the manual, the training manual, and the analysis and discussion of the case studies. This course, as you know, is already available on the ERNST website in English and is currently being translated into different other languages, including Portuguese, Spanish, German, Slovak, Croatian, among others. In terms of publications, we have already published 1 paper and the second one is currently under review. Members of the Working Group 3 have actively participated in various activities organized by the Cost ERNST initiative, namely meetings of the different groups, management committee meetings, training school activities, among others. In the coming month, we will continue to work and complete the metrics component. Our goal is to present a set of metrics for evaluating second victims support programs based on the literature analysis and on the expert group methodology, such as the nominal group and Delphi panel. Those activities have already been carried out by members of our group. And we intend to present and to publish these results by June, July of 2024. So this is what I wanted to share with you today. I would like to express my gratitude to all members of the Working Group 3 and also to all members of the other working groups within ERNST. And thank you for all support and collaborations they have provided. A special thanks to Jose Mira, the chair, and Reinhard, the vice chair of this cost initiative, for their understanding, for the leadership of the initiative, which has contributed significantly to its success. So thank you very much, and I pass the word to you, Susanna.
Thank you so much, Paolo, for presenting the Working Group 3 activities. And I would like to pick up the second victim course, the European course that has been already translated for several languages. So we can think that there will be an impact, really an impact with the course and spreading knowledge about the second victim phenomenon and about the support. So many thanks and really important results already and coming also. Thank you. And then the fourth, the last but not least, definitely working group, and let me see, I will share the slides. I will go.
Yes.
Professor Einar Skrulovici and Professor Sandra Buttigieg, please.
So thank you, Susanna, for leading this session. It's an honor to be here today and share the progress of Working Group 4 during the course of the ERNST. And I have to say that I'm co-leading this group together with Sandra, which is always a pleasure. We have great people in our group that are very active, and I will try to summarize what we did so far. So as a reminder, the main goal of our working group is to identify the barriers and the facilitators for implementing the second victim into the legislation and the curricula. And in order to do that, from the beginning of the ERNST cost, we conducted the initial survey, we call it, which included 8 open-ended questions that was that the 27 committee members of this cost action replied to, representing 24 countries. And this survey provided us some initial and mapping information regarding the condition in different countries across Europe. And according to this survey, we found out that most of the countries do have legislation regarding patient safety, but only few had legislations regarding second victim per se. And then when we talk about the curricula, we saw that only 50% of the countries had standalone courses for patient safety, and only less than a third had a standalone course for the graduate students. But then when we talk about patient safety as about second victim as a sole course, obviously we didn't find anything in this survey. And then we met in Paris, October 2022. Obviously we had plenty of online meetings on the meantime, but this was our first face-to-face meeting. And then we discussed the findings from this initial survey, and we decided that we need to take more actions in order to have some more tangible findings that we can publish eventually to be deliverables. In order to do so, we decided to do a web search for legislations across the countries that participated in the initial survey, and to conduct interviews with head of nursing and medical school to understand the facilitators and the barriers to implement second victim and patient safety into the curricula in the academia. While our discussion in Paris, we realized that those two components of legislation and curricula are working together. And actually, we're talking about an ecosystem that different layers are depending on each other and can help to make a safer environment for the patients and the healthcare providers. And this is how we initiated another deliverable that wasn't initially was part of our working group, that we are considering as the safe ecosystem. And this paper is led by Patricia and Sandra from Malta both. And we discussed this paper later on when we met last July 2023 in Vienna. And we finalized this paper, and now it's just almost going out for be submitted to a peer-reviewed journal. And during the Vienna meeting, we also discussed the findings from our initial work. So when we talked about the web search, we had more information that we had initially from the initial survey, but then some concerns were raised or issues that need to be discussed and will be discussed in this deliverable, this paper that we're writing right now. For example, many countries, as I said before, have legislation regarding patient safety, but then what is the content of this law? And if it's only about compensation for the patient, is it enough and considered as patient safety legislation? Another issue that was raised was regarding the occupational health laws, and if they are by definition containing second victim or psychological support as well, not always. So is it having occupational health law enough, or do we need something more accurate that will cover the second victim? And last but not least, we got to a situation of the chicken and egg, because we raised the concern that maybe we have countries with appropriate legislations, but the field is not implementing this legislation. But on the other side, we have maybe fields that want to implement more safe environment and interventions to prevent second victims. But if we don't have the legislation to support them, how can we do that? So these concerns are going to be raised in this paper. From the other side, we have the interviews in the curricula. We had 10 countries eventually participated in this study that our working participants, working group members conducted those interviews and translate them and transcribe them. And then we have 4 members that are leading the coding, which are from Iceland. We have Helga and Marta. From Slovakia, we have Ivana. And from Ireland, we have Mary. And they coded those interviews and got to really nice conclusions regarding what are the facilitators and the barriers for the implementation of second victims in the curricula. For example, one barrier is that many countries have the restrictions of the Ministry of Health that what's supposed to be in the curricula, and then they don't have really flexibility to make any changes. So again, we need to go to the legislation and make the stakeholders to decide that this is important, needs to be included in the curricula in the national level. From the other side, we have the facilitators, such as many countries talked about the new young generation of researchers entering the academia, and they have high motivation, and they are and they have the flexibility to do those changes. So this is just an example about facilitators and barriers that were identified in this specific study. And Marta is now leading the writing of this specific paper. And in the Vienna meeting, when we talked about those 3 different deliverables, we realized that we actually need, in order to answer the goal of our working group, we need to triangulate the information from all of them. And this is where Sandra is going to lead the white paper that hopefully eventually will answer the question, what are the facilitators and barriers to implement second victims in both legislation and curricula. So I hope that next time that we'll meet, we'll have this final answer for you all. So thank you so much.
So many thanks, Eina, for this great presentation. And we can see that there are so motivated and committed researchers also in your working group, and that sounds really great. And thinking about embedding second victim in curricula, in medical or healthcare curricula, and also social care, we could say curricula is very important, and understanding and highlighting what can be done and what are the facilitators and barriers, that's really important. So we have already passed the time. But I really want to thank all working group leaders for your great work. And this is so rich results that we are having here from different angles. And I also want to thank Professor Jose Mira for leading this ERNST. So many thanks for all of you. Thank you.
So, Eina, you have the floor. We continue with our plan. Thank you so much to all.
Thank you, Jose. Oh, sorry. So I would like at this point, Professor Shinoshiro, do you want to share your presentation on the meanwhile while I'm introducing you? Okay, so yes, I'm honored to present Professor Shinoshiro, a designated expert in patient safety and the divisional director of patient safety at Kyushu University, that has made substantial contributions to the global community. As a board member of ISQA and an executive board member of Japan Council for Quality Healthcare, he plays a pivotal role in advancing quality and safety initiatives worldwide. Professor Ushuro involvement in national-wide adverse event reporting and learning systems, underpinned by the principles of anonymity and blame-free culture, has established a critical infrastructure for patient safety in Japan. And today, we are privileged to have Professor Ushuro present the innovative no-fault compensation system in Japan, offering valuable insights that we can all glean from. So, Professor Ushuro, the stage is yours. Thank you.
Okay, thank you very much, Eina, and hello, everybody.
My name is Shin Ushiro from Kyushu University Hospital and the Japan Council for Quality Healthcare. And on this valued occasion, I'm really honored and privileged to share our experience on no-fault compensation system running in my country. A couple of months ago, I came up with the idea that I share my experience with you. When I got a draft policy statement on second victim phenomenon from Professor Jose Miller. The draft statement clearly mentioned the value of no-fault compensation or no-fault system in 2 of 7 or 8 items. So at that moment, I came up with the idea to join this session to share our experience. So let me share my slide first. Okay. Okay, and then a slide show. Okay. Okay. I hope you're watching the full screen of my slide. Okay, another thing I need to add about my title is that I am working as a steering committee member of Ministerial Summit series, which took place in London 2016, followed by Germany, Japan, Saudi Arabia, and this year, Switzerland, Montreux, Switzerland. And the next year, the summit, Ministerial Summit will go to Chile. I have been a member of the steering committee of the summit series. So I hope I will share the same experience in the summit series in the near future. Okay, what you see here is the project lines of JQ, Japan Council for Quality Healthcare, where I work. You can say that there are a wide variety of projects, such as hospital accreditation and reporting and learning system at the national level, obstetric compensation system for cerebral palsy, and quality indicators measurement project, etc., etc. And this year, we are launching soon the reporting and learning system of dental clinic. So as you see here, Japan, JQ is a foundation which are running wide variety of projects related to quality and safety. And what is important is that we welcome patient representatives in a steering committee of each project. So in other words, we work with patient representative. In other words, co-production is underway in our foundation. And on this occasion, I would like to focus on no-fault compensation. And on if there is other occasions, I will talk about reporting and learning system and other projects. And first, I would like to give you a brief background of our compensation system. More than 10 years ago, maybe 15 years ago, Japan suffered shortage of obstetricians and midwife as well, due to long working hours, burnout, and rising lawsuit case, particularly lawsuit on cerebral palsy. This is closely related to second victim phenomenon. And we also suffer the low birth rate as well. So study committee was temporarily installed in leading political party, which is current political party as well. It is called the Liberal Democratic Party. And the study committee issued a framework stating that it is normally difficult to figure out whether the delivery procedure is negligent, and the cerebral palsy, dubbed as CP, is frequently disputed in the court. The frequent dispute is one of the reasons for the current shortage of obstetricians. So the framework continues. In order to secure safe and trustworthy perinatal care, which benefit not only obstetricians, but guardians. Number 1 to number 3 should be put into effect. Number 1, the new system compensates patients who developed a disability possibly due to obstetric adverse events. Number 2, it brings conflict to settlement as early as possible, avoiding lawsuit in the court. Number 3, it establishes a mechanism that improves quality of perinatal care by investigating causes of CP. And as JQ was running a variety of projects related to quality and safety, we were appointed to be an operator of the no-fault compensation system by the leading political party. So we launched the new novel system, no-fault compensation system, in 2009, based on the framework presented by the leading political party. The system is composed of 2 dimensions, such as no-fault compensation, which works irrespective of negligence. So the payment is very quick. And another pillar, another dimension is investigation and prevention. We work with patient representatives. And we obtain as much data as possible, not only from childbirth facilities, but from families. And we publish investigative reports. And we provide the reports not only to childbirth facilities, but to patient and family. So that we would prevent and bring the case to early settlement for and improvement of quality. We quickly launched the system. So this system is not backed by legislation. So in other words, I say this is a voluntary system. However, in close cooperation with academic society, professional society, and the government, we achieved 100% of participation. Precisely speaking, only one clinic has not registered yet, but almost 100% of registration was achieved so far. And as I said, we provide monetary compensation. We provide it in 2 different ways, such as lump sum payment, as much as this amount, and annual installments that continues for 20 years with this amount of money. We do this because if we provide a huge amount of money in one occasion, the patient family might waste all of them without spending the money for babies. So we provide we apply annual installments in our payment scheme. So you may want to ask where the financial source, the budget for compensation comes from. The budget comes from a childbirth facility. First of all, I would like to say that we work together with indemnity insurance firm. This is a private insurance firm. So this system is operate in the system of insurance. So the childbirth facility pays insurance premium to JQ, and the JQ pays the premium to indemnity insurance firm on quarterly basis. But if this is the case, the financial burden is imposed only on childbirth facilities. So childbirth facilities do not like that. They don't want to pay a lot of money. So they try to get money by raising delivery fee from families. So if that is the case, the financial burden shifts from childbirth facility to families. So family has to pay a lot of money. A family doesn't like that. And there is a very unique system in our healthcare payment system. If baby is born, public healthcare insurance payer, this is a public system, pays lump sum payment, lump sum birth allowance to families. And the price of lump sum birth allowance is defined by the government. So the government raised the allowance. So the financial burden finally is imposed on public healthcare insurance payer. And the money of public insurance payer comes from employees and employers. So from my salary, on monthly basis, the insurance premium for public insurance system, public healthcare insurance system is deducted. So that's how the financial scheme works in this system. So in other words, there are two insurance systems: public healthcare insurance system and private insurance system. And those insurance systems are linked in our compensation system. This is a sort of a unique feature about our system. So people say that our system is not backed by legislation. Our system is a voluntary system, but our system is quasi-public system because the money comes from public healthcare insurance system. Okay, next, what you see here is the eligibility criteria in 2009. Now in 2022 and 23, the criteria has changed a little bit. But now I am showing the original criteria. So let's say this is the population of entire cerebral palsy patient, and we compensate according to general criteria and the case-by-case review criteria and degree of harm, criteria of degree of harm. And there is exclusion criteria as well. So general criteria is composed of gestational week and birth weight. And if patient does not meet the general criteria, they still have a chance to meet case-by-case criteria, which is very complicated, composed of pH of umbilical blood and patterns of complicated bradycardia. And the second, the impairment criteria is just composed of just the first and second grade impairment in accordance with the standard of public social welfare system in our country. And there is exclusion criteria, as I said. We do not compensate babies whose cerebral palsy is caused by congenital cause, such as genetic disorder, chromosomal abnormality, etc., etc. And we do not compensate as well patient caused by obviously caused by factors which took place after birth, like meningitis a couple of months after birth, something like that. And then we began our general criteria with 33 weeks and 2,000 grams. And as our system was welcomed by Japanese society in 2015, we were successful in expanding general criteria. It is indicated by dark pink. And then in 2022, it was again expanded because Japanese society welcomed our system, looking at the achievement in quality and safety. I will show the achievement later on in my presentation. So so far we have we had 3 different criteria, which is still evolving. The old one is this one, and the next one is shown here, and we are now working on the latest criteria, which looks like simpler to the old 2 criteria. So this slide is to show the statistics of eligible case. In other words, the number of eligible case by both year. We began with 419, which gradually decreased in such a way that we saw 382 in the next year, followed by 355, 362, a little rise, but 351 and 26. And in the year 2015, we expanded the criteria, so the figure rose up naturally, but it began to decrease to 363 and 40. So I conclude that we have observed a gradual and steady decrease in the number of eligible profound cerebral palsy. And you all know that Japan is suffering low birth rate, and the childbirth is decreasing rapidly in number. But our conclusion is that the eligible case, the profound cerebral palsy, is decreasing more rapidly than the decrease in the number of childbirth. And we are running this system with 5 committees. And I would like to emphasize that most of the committee, these three committees, include patient representatives. So in other words, our system is called co-production system in different way. And next, I would like to talk about the investigation. We get as much data as possible from childbirth facility, and we also get voices and questions from guardians, so that we would produce a satisfactory investigative report, satisfactory to families. And we have 7 subcommittees which produce a draft report. It is finalized in umbrella committee, and during the course of the production, there are many secretariats such as midwife, obstetrician, and other technical staff. They provide technical assistance to the obstetrician, neonatologist, and pediatric neurologist, midwives, and lawyers, plaintiff lawyer, and defendant lawyer in subcommittees. And then when the report is finalized, it is delivered not only to childbirth facility, but to families, so that a family would know what happened during delivery and what the quality, the procedures were during delivery. And we produce summarized edition of the report, which is 4 pages or 5 pages long, and we disclose summarized version of the report on our homepage on condition of anonymity. So we delete the name of the hospital, we delete the very detailed value related to mother and the child for anonymity. And here you see the website that disclose our summarized report. You can get our summarized report for free. And next, I'd like to talk about corrective action and prevention. But in the first place, I'd like to emphasize that we, through the investigation, we got a data on probable cause of CP, and it turns out that at present, we cannot identify the probable cause in 43.9% of cerebral palsies. This is inconsistent with the scientific knowledge of obstetrician and the midwives, but families haven't believed that. Families have thought that there is malpractice or there is negligence during the course of delivery when a baby developed cerebral palsy. But significant number of cases, it has not been given a probable cause. Initially, in the first year, this value was just 30%. 30% is significant, but much lower than 43%. And nowadays, the percentage is growing. And okay, this is yes, program for corrective action. So let's say that there is one childbirth facilities, and the cerebral palsy took place one after another in a single childbirth facilities, and the report of case A in the facility mentioned a specific procedure for improvement, followed by report of case B mentioning the same or similar procedure for improvement. If that is the case, we imagine that a similar problem still continues in the facility. So if this happens, we issue an instruction letter to urge the facility in question for improvement, and we request to return improvement report from the facility. And the facility has to describe the implementation of improvement in details. And the facility needs to report back to JQ within 6 months. We have issued 128 instruction letters so far, and yes. And if childbirth facility agrees, Japan Association of Obstetricians and Gynecologists, which is a professional society, visit the childbirth facility for education. This is a system on voluntary basis, and also anonymize the system. And JQ get a report on details of instruction or education from JAOZ, professional organization, after site visit. But JQ do not disclose the name or location of childbirth facility. We just disclose the details of instruction. For instance, the fetal heart rate monitoring was educated, or the production of precise medical chart is instructed to childbirth facility, etc., etc. Okay, now we have published more than 3,000 investigative reports. We put all of them on collective analysis to produce thematic analysis and recommendation as well. And we publish prevention report on annual basis. The report is circulated among academic society, professional society, and other societies, and the government as well. So the medical professionals related to obstetrics and gynecology learn from the report. And some data of the report is quoted in clinical guidelines for delivery. This is the table of contents of our prevention report. It is composed of qualitative and thematic analysis, and qualitative thematic analysis, and quantitative analysis as well. And I said that we produce investigative report. What is unique about our investigative report is standardization. Particularly, when we assess individual procedure, we assess the procedure with with a standardized wording. For instance, the procedure is excellent, or procedure is commonly seen, or procedure is optional, or procedure is rarely seen, or procedure is inconsistent with clinical guideline, etc., etc. So the expression or wording is standardized. So we can compare batch of 2009 and the batch of report in 2014. So in other words, we can carry out comparison analysis. And we found that comment for improvement on fetal heart rate monitoring is less often. It means improvement. Excess administration of oxytocin, which is uterine contracting agent, is less often. Mechanical ventilation within 1 minute after birth is more often. So we concluded that the specific procedures which take place during delivery are improving. So you may want to know about the trajectory of lawsuit case. Since the launch of the system, the lawsuit case related to obstetrics and gynecology rapidly declined against the entire lawsuit case. And the Supreme Court of Japan welcomed our system in their report, stating that this system is really good because investigation is carried out by a third party, independent body. And the financial burden is equally imposed on healthcare insurance, public insurance payer. And the Supreme Court expects the system to expand to cover other medical specialties. So the rapid decline of lawsuit case related to obstetrics and gynecology is probably affected by this system. And in 2020 and 21, we held ad hoc committee to review and overhaul the system. And we included all the stakeholders, including patient and families and insurance payer as well. And then what do you see here is the points of contention, particularly at that time in 2020 and 21, we unintentionally produced huge amount of reserves. So we produced a strategic plan to spend reserve. That was one of the big point of discussion. What you see here is the huge amount of reserve, but it will be reduced and reduced to zero until by 2040. We produced a strategic plan to reduce the budget, the reserve, and then. There were 4 criteria, and the gestational week was gestational week was widened in 2022, which means expansion. Birth weight was removed, which means expansion, and the case-by-case criteria, which was very complicated, but it is removed completely. And the exclusion criteria and the impairment degree criteria retained. So in conclusion, we were successful in expanding. So the sum of the criteria was removed like this. And we were successful in expanding the general criteria to dark pink. And our system is quoted and paid attention to by United Kingdom, because United Kingdom is currently suffering birth injury and the scandal of series of birth injuries due to malpractice. So I was invited to the select committee of the House of Commons UK Parliament last year, together with international experts from New Zealand, Sweden, and Virginia State of the United States. And the committee published the final report last year, which includes our data. And last week, yes, maybe last week, I also worked with Imperial College of London, and they produced a video clip, including my interview. I described the value of no-fault compensation system, and the video was aired in a big event last week by Imperial College London. This is the event called HSJ, Health Service Journal Patient Safety Congress, which took place last week, in which my video was aired. So there are some takeaways. JQ successfully expanded the compensation system for CP along with the advanced standard in medical science, as the system compensated a large number of CPs and families and achieved a lot of quality and safety improvement. While most committee members were in favor of the expansion, while public insurance payers representatives were initially careful about possible expansion of expenditure, but we included public insurance payers, and they are finally in support of the expansion. Presence of stakeholders in the committee, such as healthcare payers who pays the insurance premium, and association and payers association and transparent process is a key to get the agreement on the expansion, because they pay insurance premium in real terms. Okay, that's all from my end. So thank you very much for listening, and I'm happy to take questions. I will stop sharing my slide. Thank you very much.
Thank you so much, Professor Shino. I have to say it was a fascinating presentation, because I looked at the presentation in advance and I said, wow, I'm waiting to hear about it, and it got even better than I thought it will be. And I have to say that your title is the compensation, no-fault compensation system. But what I hear when you present your presentation, that it's actually, as I previously stated in the working group 4, that it's actually an ecosystem that you talked about, because you talked about the organization did like a second order learning process that including the families and the patients into the process. So it's something much more bigger than just let's compensate the patient.
Exactly. Yeah. Exactly.
Let's learn. It's combining the learning with all the stakeholders involved in that. So I think it's incredible that you reached that. And I have to say to us, because potentially, theoretically, I can see the advantages that this movement can cause. But do you have any methodological assurance that you tested the improvement of this shifting to the compensation system?
Okay, thank you very much for your question on the quality improvement. And well, actually, I said in my presentation, and the key point is to produce standardized report. So if we produce standardized report, we can compare one with another. So in order to produce standardized report, we initially produced list of wording, list of expression to assess appropriateness of individual procedures. So we just use the word from the list, and we do not use word we like. So in that way, we have produced more than 3,000 standardized report. So we compared old batch of standardized report with the latest batch of standardized report, and so far we found that fetal heart rate monitoring and administration amount of oxytocin, which is uterine contracting agent, and neonatal resuscitation, all three procedures has improved and still improving. That's the way we demonstrated improvement.
Did you see any increase in the OBs number and midwives, maybe? Because you said that you had a big shortage at the beginning.
Okay. Yes, thank you very much. Yes. I thought I included the figure of obstetricians and midwives, but there is a national statistics of obstetricians in my country disclosed by the government, Ministry of Health. The figure was lowest in the year of 2007 or 8, which was the time we were preparing the system, and after that the figure rose up gradually. In other words, the population of obstetrician is gradually increasing, continue to increase after we launched the system. So what was good is that the mindset of obstetricians and the mindset of young doctors dramatically changed. Before the launching the system, they felt that they were not protected, so they were really exposed to risk. But after we launched the system, they have felt protected by society. So the obstetrics is a sort of a professional specialty that deserves to join. So that's the mindset change among young doctors and other obstetricians. So we are still observing the steady increase, but little by little, but increase in the number of obstetricians. I don't know about the population of midwives. Maybe it is leveling off.
Thank you. I see that we have 2 questions from the audience. Jose?
Okay.
Well, thank you so much. It's amazing, a great experience. And I suppose, I am sure that there's a lot of hard work behind the slides and behind. And I would like, if it's possible, I know that it's too late because in Japan it's not the same time than here. So many thanks for participating in this forum. Thank you.
My pleasure.
Thank you. Thanks a lot. If you can explain some other points, as you mentioned, about attitudes of the citizens, about the attitudes of the patients, about the attitudes of the professionals, because of course they are a hard work, a technical hard work to ensure improvements, to elaborate reports, to analyze the root causes of the adverse events. But I suppose that also you need to manage the attitudes, the social stereotypes about errors, and many other social aspects around this experience. It's not only from the point of view of a technical work, also about how to explain some tips for us to be used, your experience in the future, because really it's a very amazing experience from the beginning to the end. How do you close the quality cycle, and it's possible to reduce the reserve of money because you expect a reduction of the harm to the patient. So that's great. Thank you so much.
Well, thank you very much, Professor Jose. And initially, the patient and family and small population of obstetricians were really dubious about the system, because the obstetricians said, small number of obstetricians said that families will sue doctors and midwives more often with the money they get from the system, and the family said that the system just give money to families to not so that family would not complain anymore. So from the beginning, we include those stakeholders, families and obstetricians in introductory committee of our system, and there were volatile discussion in the introductory committee, but we reached an agreement that we not only provide money but also carry out investigation and prevention. And then years later, it turned out that the lawsuit case began to decrease rapidly. So the obstetricians were really happy with the decrease in the number of lawsuit cases. So they were really happy, and the family were really happy because investigation and prevention were carried out, and they get money. So so by operating for a couple of years, we were successful in convincing those two stakeholders who were reluctant initially. That's the lessons I learned.
Thank you. And we have last
Thank you.
question. Not that we are out of time, but I think that Sandra was waiting very nicely. So we'll finish with her question.
Okay. Thank you very much for an excellent presentation. I am really intrigued with cultures. So what works in one part of the world? My question is, can it work in other regions? Can we do we have the culture of actually dealing with important stakeholders, which in this case, there are also the lawyers. And the lawyers, when they have a lawsuit, you know, probably they are saying, wow, I have another lawsuit. You know, we've seen this in the US when we used to have the wave of lawsuits coming from the US to the rest of the world. So I wonder, we heard that you had also yourself involving yourself in the UK. So in a way, you are already closer to Europe to understand how the different stakeholders work. What is the culture of dealing with such situations? And therefore, do you think that Europe can actually go down the same road and ensure that we can implement across Europe widely what you have managed to do so successfully? And now we have evidence from you. So it's not just saying, well, we think that, you know, the number of lawsuits will go down. There will be more satisfied healthcare professionals. Hey guys, we are losing so many healthcare professionals because of lawsuits as well, you know. So what is the trick? Is it the Japanese culture that's winning here, or can it also extend to the rest of the world, in our case in Europe? Thank you.
Okay. Thank you very much. Humbly speaking, I wouldn't say that our system applies to all of other countries because it depends on the local context of each countries. But I can say that medical professionals of many countries are really interested in having embedding similar system in their healthcare system, because I was invited by, for instance, Malaysia, which has a healthcare system similar to United Kingdom. They are suffering from similar issues. And Singapore and Thailand, China, and I also visited Italy and UK as well. And I told you that I joined the committee of House of Commons UK, and it was a series of committees. And in another round of committee, there was a big discussion over the value of lawsuit system, court system. And the conclusion was that lawsuit does not improve healthcare quality. Lawsuit cost very much. So UK need alternative system for this issue, the birth injury. So the damage payment is skyrocketing, and the most significant number of it goes to lawyers and his or her associates. So the conclusion is that they need alternative system. So I think the medical professionals who wants to have a similar system is emerging in many countries. That's what I can say. Thank you very much.
Thank you so much, Professor Shinoshuro. Unfortunately, we have to finish this session and shift it to the next one. But I would like to thank you for take the time to present it here, and I'm sure that many of us will be in touch with you later on and try to collaborate and expand our knowledge. So thank you so much.
My pleasure. Thank you very much.
So thank you so much, Professor Lucero. It's an amazing experience, enough as described, and all of us appreciate very much your effort participating in this forum. Well, now we have other speakers with well, a funny and at the same time fruitful suggestion for work in our network, of course, open to all of the people that follow this session. And just a moment, because our speaker need the link. Alejandro, please, could you send the link to Basia or send to me and share by mail? Just a moment. Basia, I tried to. Yes, a moment. Oh, Basia is coming. There is maybe it's a technical problem. Sorry about. We are trying to resolve because we are not able to find the link. So, Alejandro, could you check if Basia is trying to connect with us to this session? So, I'm very sorry about, but well, Bohana, if Basia in 1 or 2 minutes is not able to connect, if you agree, you can start your session. I am waiting by, oh, it's coming. Okay. Basia, hello, good afternoon. Hello, Basia. Can you hear me or no? There is some technical problems, I think. Sorry about. Yes, Basia. Hello. Yes, but I think that you are following the session in the YouTube link, and this is a wrong one. I send you the right one, the right link by WhatsApp.
Maybe we can start with another
Okay,
section,
I am sending.
and we can
Don't
stop. We have
okay.
four
One
presentation, so we can make a break, and then Basha can join us, maybe, if you agree. I couldn't hear. Sorry, Jose. I can't hear Jose. Let's start. May I start? Yes, no, I couldn't hear.
Jose, you're muted, I think, or we cannot hear you.
I couldn't hear.
Jose, we cannot hear you.
Hello.
Hello, hello, Masha.
Hi.
Hello, Basha. It's nice to see you.
It's so nice to see you, and I don't know if Sheen is with us.
But we've lost
Jose.
I
we've
know.
lost the sound
Yeah,
from
but
Jose. I think, Jose, you need to log out and come in again.
oh yes, probably.
But we couldn't hear you.
Okay, do you think I can start my presentation?
Yes.
Which is kind of very brief, and as Jose said, it's just the starter, maybe, of some of our additional activities within COST. Okay, I will try to share my slides now. Is this okay?
You can start, Basha.
Okay, can you see my slide?
No. Now we lost you, Basha, again. There are some technical problems, so I couldn't hear Basha, and I couldn't hear Jose.
Okay. Sorry for.
Now we can hear. Okay.
Well, let me to introduce to Basia. Sorry, Basia, because I am not able to help you. Sorry about. Well, Basia is part of our consortium. She is working for many years ago in quality and also in patient safety. She was one of the co-founders of the first quality institute in her country, and during many years is collaborating in several international organizations, specifically on quality and patient safety. She is a founding member of the Polish Society for Quality Promotion in Healthcare. And well, if our host for the next management committee in Krakow in 1 week. So Basia has a good idea to promote in a different manner the knowledge about the second victim phenomenon. And Basia, when you are ready, you have the floor.
Okay, thank you very much. I will try to and please tell me if you can see my slide.
Yes, I try to show. Just a moment.
Can you see the slides?
Yes, just a moment. Alejandro, could you show the slides from Basia? Are you ready to show the slides? Just a moment.
The slide.
No, I try to show. Just a moment. If I am able, yes, here. Okay.
Maybe, can you see them?
Can you see the slides? Yes, okay, thank you.
Okay, can I start?
Yes, when you are able.
Yes, I ready. Well, as you said kindly, this short presentation has been aired by the originate
Basia.
By the World Health Organization recent 15th of September.
Micro. I am not sure if the connection is working right, and there are some shortcuts in your speech. So maybe the micro doesn't work in a right manner. You can check or try again, please.
Okay.
That's good now. Okay.
Okay. I will try to change the internet. Okay.
Okay.
Just a minute, please.
That's right.
I'm so sorry. Is this better now?
Yes, I think so. Thank you.
Okay, thank you. And I have really very much apologize for this inconvenience with me. It's just that I am not at home and I use the internet, well, now from my phone. I hope it will work now. Well, so let me start from the scratch. Again, this short presentation is a trigger for the ERNST consortium to maybe consider including storytelling of healthcare professionals who have been harmed by the adverse event during the practice, as storytelling is a very powerful tool. And I was very much impressed by the initiative of WHO on patient safety storytelling. As I was looking for some literature on this, I just by chance found that already in 1962, John Kennedy has mentioned the 4 dimensions of consumer rights, such as right to safety, to be informed, to choose, and to be heard. So we are really not very innovative talking about safety in 2023, but it is good that it's not only the safety of consumers, and that safety of consumers is embracing not only patients, but also the professionals, at least in our project. Why storytelling? Well, there are books written on this, persuading the impact a story told in the right time that can have on the audience and public. They say storytelling wins hearts and changes minds. And definitely, I think it is worth to pursue that. We also in our project consider collecting stories told by those professionals who would be willing to share it with the wider audience at some point. As I said, storytelling is a big business now. There are many publications on the market about this. But what we would like mostly to concentrate on is the healthcare storytelling by those with lived experience, as it is said. So if we look at what do we have, and I was mapping the internet for some publications and some information on storytelling related to healthcare sector. The majority of the stories we can find come from patients and families. And this line is in tune with WHO Patients for Patient Safety, big and very wonderful group of people all around the world who constitute a network of patient safety advocates or patient safety champions. And as I said, WHO is planning now this project on collecting some more stories and publishing it, but also within the line of the global patient safety plan, which will finish in 2030, the involvement and engagement of patients and families also has a phase of telling about the experience of harm and sharing it with the wider audience. So it also is in line with the global patient safety movement right now. And I know that there are also there have been some local initiatives. It was the famous Conquer Silence in Canada, run by the Patient Safety Institute. I think it was 2 years ago and related to the World Patient Safety Day. There also are some initiatives in Spain, as Jose, you have mentioned how you did celebrate the 17th of September this year. And there are some initiatives in USA, and I made many dots because I'm sure there are many, many others. Yet I know for sure that in my country, we do not yet have started to somehow to manage this area. There are also some stories by healthcare workers, although there are less of them, there are much fewer. And they are very, very powerful messages though, but mostly concentrate on patient safety, on the harm that you have participated in, and on the difficulties of disclosure, telling patients and families about harm and about what happened. And it's also about usually stemming out of these messages of experience and is what improvement has been done in a given organization, or what change of practice has been observed in an individual itself. Yet really very few, and I must say I have found just one that has mentioned the issue of suffering from the second victim experience. So I think, this is our small 10 experts WHO group on patient safety storytelling I was mentioning to you. And here on the left is Liam Donaldson, who is WHO Envoy for Patient Safety. And he is a great mentor of this project as well. What could be the objective if we decide to develop this area? This is just my attempt of defining what it might be. So in my view, it would provide a framework, a guidance, and examples to engage and empower second victims to effectively develop and deliver stories of carers who experienced unsafe care, taking into account that it would raise the awareness of the second victim phenomenon, and also would maybe stimulate the proactive response of an organization, of a healthcare organization, and also should be, as a result, actionable for the healthcare leaders, for the environment of clinical teams and healthcare institutions, but also for patients and families who also should be aware that this coin has two faces, and that harm impacts not only them as receivers of harm, but also has its imprint and imprints itself on the healthcare professionals. So what could be and what should be, I believe, the key themes that should be found and should be present in the storytelling? Well, it's obviously all those very negative and bad emotions that I tried to list here. It also should definitely relate to shame and blame culture and the professional's reputation in case the mistake happened or the adverse event happened, and also include the effect it not only had on an individual, but also on the family of a doctor or a nurse. It should also include definitely the ideas that were born as a result of such negative emotions, such as quitting the profession, the depression, some suicidal thoughts, maybe even. And should also, because few doctors in the stories I have managed to find, that there was stressing and emphasizing the stigma which they felt after seeking an assistance with their peers, as they were perceiving themselves as not enough professionally competent. And this was a very difficult feeling and emotion. And for many of those, also being a part of adverse events was a life-altering, life-changing experience. Most of them say it with relation to patient harm, but also I very much believe, which has not been clearly articulated, relates to own emotional stress.
Yes.
And apart from these, there should also be some action. They should evoke also and promote certain types of activities, such as they should emphasize the importance of peer and organization support or lack of it, the existing or non-existing in a given situation assistance programs and networks, but also the importance of the coping skills, coping with stress, with despair, conquering those negative emotions, which only allows an individual to go on and to not to quit the professional career. And what I think also should sound and be, we should also hear the expectation of patient safety education, both on the under and postgraduate levels, as a very important element of medical education, and as an element that would not leave a given person vulnerable and without somehow, let me say it, like unarmed human being. unarmed, unable to cope with the situation, not prepared during the studying years. And also, I very much believe such stories would gain an interest from healthcare policy making to promote those programs, those support networks, those programs, not only within the healthcare organization, but also on a wider level of a country or region. But the core message, I very much believe, such as storytelling of second victim experience, is this. That means most important is that you should not lose the ability to reevaluate, reassess, and to adapt, because otherwise it will not be possible for you to compensate for what did not went very well before at a given moment. So, Jose, next steps to be considered.
Yes, because we need to summarize, because we need to.
Yes, of course, because I took so much time with my internet. Okay.
Yes, thank you.
Well, next step, storytelling toolkit would be very useful. WHO is planning a storytelling toolkit for patients. Maybe we could have it for healthcare professionals who would like to share their experience as well. How do we find those stories? Well, there are several ideas here. Develop ERNST call for stories, or we can directly solicit stories through an invitation within our network. What might be also good is to appoint the experienced storytelling mentors, which are familiar within the local or regional culture, because those stories need to respect, of course, the regional culture. And I very much believe if we decide to go this way, it would raise the awareness of the second victim phenomena and maybe stimulate as well the proactive institutional response after which we are after. Thank you very much.
No, thank you so much, Basia, for your presentation and for sharing this very good idea. Storytelling, as you explained before, is a new strategy that WHO is introducing to increase the awareness about the patient safety, and of course will be a very useful tool to share the emotions, the feelings, and the consequences of the second victim. So I fully agree with your suggestion, and I think that if you think it's good, during our meeting in Krakow, we can identify the critical steps to introduce this tool in our network. So we need to invite our colleagues and patients also, as in the sample from Japan, from the very beginning, to involve patients in the decisions. So maybe we can organize a storytelling initiative in our network. So thank you so much for your interest. You has gone the first step, but I'm sure that many other steps later. So thank you so much, Basia.
Thank you very much, and I invite you all to Krakow next week.
Yes, thank you, Basia.
Jose, can I just make a very quick comment?
Very quick question,
yes,
because Bohana is waiting for us.
Yes, Basia, this is really great. And I invite everybody to think about storytelling also within the ethos of the paradigm shift from patient-centered to person-centered care. Because if we have the infrastructure for person-centered care, storytelling will be more forthcoming. Thank you.
Thank you, Sandra. And Basia explained, this Friday, we will give the awards to our awareness from the storytelling in Alicante, in my city. And we have more than 50 stories about patient safety, about the feelings, so it's a great experience. And I invite you to follow us by internet this Friday. Bohana, you have the floor. Thank you so much for prepare this session. Basia, thanks a lot for participating in
Thank
this
you.
forum.
See you.
Thank you very much. Dear colleagues, good afternoon. And I think we will share great ideas in this forum. It was excellent today, and I hope we will have excellent work tomorrow too. I would like to open the speakers corner for young researchers from different European countries. I think it's a great opportunity for young researchers to share their work with us. They will describe their work about Slovakian qualitative research on psychological safety, case study from Croatia about psychological help for employees, raising awareness through social networks in Serbia as a good modern tool for dissemination, and collaborative work of researchers from Ukraine, now in Norway, with colleagues from Croatia and Poland. First, I would like to invite Ivana Skov-Malova. She is a psychologist with PhD. She is a researcher at the Department of Health Psychology and Research Methodology at Pavel Josef Šafarik University of Košice, Slovakia. Ivana, the floor is yours.
Hello, everybody. Thank you for giving us the opportunity to introduce our research. I will share my screen in a second. Okay. Can you see it? Is there a presentation already?
Yes, it's
okay.
Everything is okay.
Thank you very much. So I will try to be really fast because I have around 7 minutes, and we have really rich and nice findings in this study. So the study, we call it How is Psychological Safety Perceived by Slovak Healthcare Professionals? And it was also a part of diploma thesis of one of our students. So we are talking about psychological safety, and probably a lot of us know that it is defined as a shared belief of medical professionals that their workplace is safe for expressing their opinions, with no fear or humiliation or punishment. And our hypothesis is kind of that communication of concerns about patient safety may help to protect patients as well as to protect healthcare professionals at the end. So kind of higher psychological safety can mean better patient outcomes and better healthcare professionals' performance. In Slovakia, almost no data exists on this topic. It's very hard to find any data on this. So our aim was to explore qualitatively how medical professionals in Slovakia perceive psychological safety in connection with communicating concerns about patient safety. So it was a qualitative study. We performed semi-structured interviews with 16 medical professionals. We are going to continue with this research later on with our students, and we see our sample was 16 medical professionals, mainly doctors. And we, as analysis, we used conventional qualitative analysis combined with consensual approach. So what are our research questions? We really, as there are almost no data, we really tried to look at it as like what will emerge in our interviews with healthcare professionals. But we had like 3 questions, and this is, how do medical professionals perceive errors and adverse events in their work environment? Then the second one, how they react in situations when patient safety could be or was jeopardized. So what are their reactions? And the third one is how medical professionals perceive the communication itself on patient safety concerns in their work environment. And by finding answers to these questions, we try to answer like how do healthcare professionals perceive the topic, their patient safety, because patient safety has many levels kind of. Yeah, so it's not only speaking up or only perceiving how they can communicate. That's a lot of different aspects. So I have longer presentation with quotes, but I will go really quickly through it. And here you can see the main findings of the first question. So how they perceive adverse events. We found out that adverse events or errors are mostly perceived as being expected as a part of healthcare profession. A lot of healthcare professionals said, this is human, this happens all the time. All of us kind of caused or were involved in some adverse event or error or near miss or something like that. A lot of them told us that it is something really common, really human thing. The other finding is that they thematized the responsibility for adverse events or errors, and there is no consensus on this topic. Some healthcare professionals take it as a personal cause, personal responsibility. Some take it as a collective thing, and some are saying that the responsibility is in the system itself. Then the other finding is that on impact, when we asked, like, how do you perceive it, they started to talk about impact, about negative impact of adverse events on healthcare professionals. Here you can see some quotes on the causes of adverse events. So we try to make some categories, and here you can see just a representative quote to these categories, just to illustrate how it is. So, for example, errors being part of healthcare work. So everyone has already made a mistake, greater extent or lesser extent, yes? We are just humans, we make mistakes, or because 10 more patients are already knocking on the door, absolutely everyone makes a mistake. Then on the responsibility, so here you can see an example of individual responsibility, collective, or the system responsibility, how it is represented in their perceptions. I can definitely send you the presentation so you can take a look at it later, because we don't have time to go through all of it. Impact, stress, unpleasant feelings, fear of sanctions, feelings of guilt and failure, no positive experience. Like there were some that were saying that I can learn from it, but it was really marginal. It is really perceived like something harmful for healthcare professionals, something stressful. The second question we were asking on the reaction of healthcare professionals when adverse event or error occurs. So here we have some distinction between peer reactions and superiors reaction. Peer reactions were mostly like they said that we notificate about it, we try to correct the situation, we try to prevent such similar events. Some of them say they just keep silence or pretend that nothing happened or do not interfere. So these are kind of things that emerged. It doesn't mean that they all have like similar amount of responses or are more important or less, but these are in this discourse about what are the reactions on adverse events. Superior reactions mostly are perceived as very negative, exaggerated, sharp, repressive, punishing, insufficient, or unequal. We will show you some examples. Less commonly, the reactions were supportive or corrective for the situation. And then we also ask how healthcare professionals reacted when they were alerted that something may happen in their behavior. And mostly they said, I would accept it, I would appreciate it, I would try to correct things and prevent mistakes or so. Here you can see a few quotes, but I really need to go through it quickly. And then the last one, findings on perceived communication on patient safety concerns. We identified facilitators and barriers for communication. And here you can see on this slide that as facilitators, they can see, for example, the opportunity to communicate one's concerns. I will show you some quotes. my point of view, I think I can express my opinions freely. So this is a facilitator to talk about possible mistakes. Human-friendly atmosphere at the workplace. Appropriate form and timing of communicating concerns. So it's not always the good time. We have to find a good time when it is okay to communicate. Or the facilitator is also an appropriate approach of superiors. So we see that healthcare professionals need support from superiors, not punishing or something like that. I will go back to this slide. As barriers, we identify mainly hierarchy and fear of consequences. And here you can see a few quotes. One respondent said, with management, no, it is absolutely pointless to talk about because it is always just one opinion. It doesn't matter if there is a better alternative or what the result might be. So there is a really like an opinion that it doesn't make any sense. It's not important. Nobody will listen to me. And fear of consequences. Here in this quote, it is said that it might reflect in some way on their future, like healthcare professionals' future, career advancement or staying on clinic. So people are afraid that they would lose their job if they say something. So what are the implications of such findings? I think that this is rather common opinion or something that connects all what we are talking about today, that we need to train healthcare professionals, but on all levels, not only nurses or doctors or so, but also management and other important stakeholders to appropriately respond when something is happening or when near miss happens or adverse event. We need to open the professional discussion about mistakes, accountability, causes, and so on, especially in Slovakia. We are not talking here about other countries. This is really about how it works here in Slovakia. Of course, we have only 16 respondents, but we will have more, so we will see how it goes. Then to standardly analyze errors and adverse events, evaluate procedures, and support learning from mistakes, which is kind of not existing here. Very important thing is to address power issues at the workplace, because very strong finding is that, for example, peer support is quite adequate when something like this happens, but there is a really poor support from superiors who may have some power upon healthcare professionals working with patients. And of course, to create safe and transparent way of reporting errors and adverse events. So that's it. Thank you very much. I hope you enjoyed the presentation.
Thank you very much. It's very interesting. I hope we will have the opportunity to go deeply in your investigation, but now we haven't enough time. We are now on the second presentation. Second presentation will present Dr. Filip Mustac. He is PhD student and resident of psychiatry from University Hospital Center Zagreb. After all this presentation, I don't know, maybe we will have time to for few questions, but now we have to go on quickly. So Filip, the floor is yours. But we couldn't hear you. Maybe something is. We couldn't hear you. Do you have problem with your microphone or something? What can you do now? Are you on the computer or? Yes. Maybe you can turn your presentation and maybe you can connect again. But
yeah, do you hear me here? Yeah.
Yes, now we hear you. Yes.
Oh,
So,
nice.
so please, your microphone, you have to.
Yeah, I think it would be problem with
decrease
microphone. Yeah, because
yes,
now I'm
cacophonia.
mobile phone. Maybe maybe that I try to resolve it and that was after me, or
Okay, you can speak please quickly, and if you can, your phone maybe.
yes,
Volume on your phone.
like I have problems with computer, and then yeah, but it won't work like this from mobile phone. Yeah.
Okay. So, floor is yours. You can try it by mobile phone, please. And please be quick.
Okay, I hope it won't be too. You hear me well, or?
Yes, yes. Little cacophonia, but okay.
Yeah. Okay. Yeah, I'm sorry for this, but okay, we don't have time now to do it better. Maybe. Is it maybe better like this? No? No.
Yes, yeah.
Okay. Okay, thank you very much for your invitation, and I think it's really nice. All those presentations are really nice to see. Again, Professor Mira and Professor Buttigieg and all the other who were last year in Zagreb. So my today's topic would be experiences from the tour of psychological health for employees in University Hospital Center Zagreb. It is a bit for so maybe I'm trying. Okay, so the hospital team for psychological health. That team is established actually during the era of lockdown in Zagreb and earthquake, which was in March 2020.
Možda možeš samo stišati zvučnike ove da se ne čuje. Samo ove zvučnik stišati.
Moj.
Da, zvučnik. Jako je glasan zvučnik na ovome, pa onda možda samo... Evo sad možemo probati.
Jel ovako?
I'm sorry, yes. Yes, now it's okay. Thank you very much.
Great. Okay, I think it's now much better, yeah?
Yeah, it's excellent now, please.
Okay, great. Okay, so this hospital team for psychological health was established in 2020. It was actually, the aim was to help the people after the earthquake and after the lockdown started in Croatia, in the whole world in general. On the other hand, I wanted to say something about, because we had already established our crisis center, but I will talk about it later. So during this time, this crisis committee for psychological support was established. The goal of establishing those team was that with all different forms of psychological help, that we facilitate coping with all demands and stressors. So as you know, during the COVID era, employees from other departments also had to work in COVID departments, regardless of what's their initial residence and what is initial profession. I think what are they experienced in those things or not. So in many people faced, and employees faced, the fear, stress. They felt like they having lack of competence for working in the common department, and in general those were new and changing things. Some people were there for 2 months, some for 3 months, and more, and so on. This hospital team for psychological help, we recognize the importance of destigmatizing this seeking support and togetherness. So what was the purpose of and what this team did was that going to the COVID departments, talking to employees, providing emotional support. So this crisis staff was consisted of nurses, psychologists, and psychiatrists. We really have to outline the really role of our nurses, who were also having like this the core stress management in nursing, and they had like peer support, like nurse and nurse support and so on. So what our numbers told that we had individual interviews, so it was 123 employees which sought support. So it is basically it was formed into bowling groups, which is the peer support group with the aim of detection of emotional problems within the team. And we also try to have like autogenic training, which is a relaxation technique to have like also mindfulness, conscious focus on here and now, and with the aim of relaxation and having feel of being somewhere mindful.
I'm sorry, we can hear only first slides. Are you?
You don't see slides, yeah?
Yes.
Yeah, I see them, but you obviously not. I'm really sorry. I didn't know that I would have such problems.
Share screen. Maybe you can stop and then share screen again. Yes. Now
maybe
it's
like
okay.
this is better.
Okay.
Yeah.
Yes. Like this.
Okay.
Yes. It's okay.
Okay. I'm sorry. So we had like psychoeducation. So it was with the aim of sharing feelings, taking time for themselves, with improving and encouraging physical activity, sleep, nutrition, socializing, music, and dance. And as I said, our main nurse of our department, she organized the course Stress Management in Nursing. This is also the letter of our hospital team for psychological support. What I also wanted to say is that we also had after the war, so approximately around 2000, our clinic established this hospital crisis team for psychological support, which also was then the good basis for our hospital team for psychological support. What we think that employees still are not enough aware of second victim phenomenon, and what they should and what should they know, what they should report and what shouldn't, and so on. So our experiences so far are those that the team was mostly contacted because of complicated interpersonal relationship on the departments. So all such like ongoing interpersonal problems, more than employees were aware of second victim phenomenon on what they should report as adverse event and another problems within the team. So this is actually the Center for Crisis Intervention and Suicide Prevention, which was established after the war with the aim of helping actually creation more veterans that had many problems with managing PTSD symptoms. But of course, now 30 years after, it's the aim is also to help people with acute stress reaction. So people are often coming after the complicated life situations, marital family problems, after robberies, assault, separations, and losses. And it's also always open for our employees in our hospital. So we also have 24/7 phone line. So it's always possible that somebody calls that number. When we are speaking about the numbers, so during this COVID era, we had a slight lower number of acute hospitalization, as you can see on this slide. We don't know actually, Professor Knežević and I, we discussed this, but we don't know actually, is it what is actually the main purpose and main reason for it. So maybe it was about the bed occupancy rate, which we see that it's in 2020 slightly lower than it was before. Also, these reported adverse events, I don't know because of the colors if you see well, but here are all. So this like orange line is are all adverse events, and this serious is like gray, green or gray line. It would be here. So we don't have like reporting of serious adverse events, but okay, last year at least we have like some. We are improving culture of reporting adverse events, so which is, I think, very good for our hospital. That could later Professor Knežević say more about it. And as we can see, these reported serious events were also lower than before. We can now discuss, but I think we don't have much time that to discuss it at the moment. So after serious events, mandatory is meeting with the superior and colleagues. Why we think it's important? I think we think that it's important to analyze the causes of adverse events, that we do corrective or preventive measures, and we want to inform the workers about the team for psychological help in our institution, because at the end, we are the biggest hospital in Croatia, so I think it's pretty much that we have such opportunity to also be example to other hospitals in our country. So what are the future possibilities? I hope that we will find some new ways of coordination between the hospital team for psychological support and our Center for Crisis Intervention and Suicide Prevention, which is very often the first line of the first line of our defense, to say it in a such manner that people usually and our employees usually go to seek for the psychological support and to see at the end psychiatrists and so on. Even though we have also other problems we also discussed a few days ago, which are like also stigmatization of seeing and seeking for psychological and psychiatric help and so on and so on. And also we have like education and implementation of knowledge of second victim phenomenon in the hospital, because the more people know about it, the more they will report it, and we will have like better quality of in our hospital, and in the end we hope less serious adverse events. So I hope I'm on time, so thank you for your attention.
Bojana,
you are muted.
We can't hear you. You're muted.
Sorry, I didn't hear if you asked me something.
Bojana, we cannot hear you.
Sorry. I'm sorry. So I said that I say thank for Philip. It's a very nice case presentation, and I would like to invite Ivana Zimonjić. Ivana Zimonjić is pharmacist. She works and she's PhD student and teaching associate at University of Belgrade at Faculty of Pharmacy. So thank you, Philip. And Ivana, now it's your floor.
Hello. I will share screen. A second.
Okay, Philip, yes. Now it's okay.
Is this okay now?
Yes, I think it's okay.
You see presentation?
No.
No. Okay. Just a second. Do you see presentation now?
Yes, thank you. You can
Oh,
start, please.
great. Okay. I'm very glad to be with you today. My name is Ivana Zimonic, and I'm coming from Serbia. I'm a PhD student and teaching associate at Faculty of Pharmacy, University of Belgrade. And today I will talk about rising awareness of the second victims phenomenon in Serbia through social networks. And for this purpose, I created one newsletter, LinkedIn newsletter on Serbian language, which we can call something like support, develop, and build resilience. And it is for personal development of healthcare professionals, patient safety, and building personal and organizational resilience and business sustainability. In this process, we had to explore healthcare professional needs and new standards in education before we create the program and form our multidisciplinary team. In this process, we had key opportunities. At first, COVID-19, then timing with ERNST training school in Zagreb last year in October. And we had a big support from ERNST and from my mentors, and the impact of this topic on health and work-related outcomes. This program is completely innovative in Serbia. We have a multidisciplinary team with HR professionals, healthcare professionals, consultants, professors, and educators. We use ERNST training manual for patient safety material, second victims experience, support programs, health and HR work-related outcomes. And it is 24 hours, 7 days a week available online and completely free for all healthcare professionals. Here you can see newsletter goals. At first, convenience, patient safety skills development and business skills development, something like leadership, resilience, communication, teamwork, time management, change management, and problem solving. Compliance, Health Council of Serbia accredited this education, and satisfaction of healthcare organizations, pharmacies, healthcare professionals, and etc. Here you can see proposed timeline. We started in October 2022 after ERNST training school. It was my inspiration with creating awareness with educational strategies, red flag experiences, and stakeholders. In October 2022, we started with development, with identification of resources and needs, and program design and preparation. In November 2022, we piloted it, make it happen, and dissemination of this program. In July this year, we started with evaluation and got feedback and results. And for October 2023, in this month, it is planned the sustainability study. We plan to overcome barriers, we plan publicity and staff motivation. Healthcare staff motivation improvement. Here you can see our multidisciplinary team, me, creator and researcher, Professor Lazar Dražeta, my mentor, lead researcher from HR field, Professor Valentina Marinković, my another mentor, lead researcher in pharma field. You can see my contacts, and you can see healthcare HR newsletter link. I don't know, can you see this from this view, but I will click on this. Do you see this?
No, we couldn't.
No, you could see. Okay. Okay.
But I will remember.
Yes, we have 39 editions, 39 topics, and we started with patient safety and ERNST material in 2022 in October. It was our first edition, patient safety, and
excellent. Congratulations for this.
Thank you.
It's very nice work and then very modern tool for dissemination and I like it very much. So thank you very much.
Thank you. And training school was inspiration for me, really.
We will invite now Anatoly Koncharuk. He works now in Hauk School of Management in Norway. Anatoly is from Ukraine, and we have cooperative research in the topic of second victim. So, Anatoly, floor is yours.
Hello, colleagues. May I open my presentation? Can you see it?
Yes, we can see it.
Okay. So my topic is how serious is the problem of second victims for medical staff, a case study. And first of all, I would like to thanks to ERNST Cost Action and for supporting the study by STSM grant, as well as host supervisor, Dr. Bojana Knieżewicz, and all the medical staff that agreed to participate in this survey.
We couldn't see, we see only first slide. Maybe you can turn on the left side. Turn the slides on the left.
And now?
No, only first one.
So what should I do?
You can see on the right down there. Yes, here, maybe.
And now? Can you see?
Yes.
Okay. And now you can see introduction slide, yeah?
Now we can see first slide with thanks, cost action, acknowledgements slide.
Maybe it's some kind of delay, or I don't know.
Okay.
Should I will try to change slides. What about now? Can you see?
No.
Sometimes you need to close and refresh the slides. Sorry about.
Stop sharing and then share again, maybe.
Okay, I will try again.
Sometimes it happens on some platform. You have to stop and then share again, and everything will be okay.
What about now? Can you see?
And there slideshow there down there.
It's okay now.
We can see introduction slide.
Introduction. Okay. So as you know, must be annual cost of preventable adverse event to 30 European nations in 2015 was in the range of from 17 to 38 billion euros, and total disability just at life years lost due to adverse events was 3.5 million, of which 1.5 million years, or about 43%, could be prevented. However, this figures is not including the emotional disturbance suffered by patients and the relatives and involved medical staff. We name them second victims, which cannot be measured in money terms. So can you see the next slide now? No, I don't hear.
You can click on the left side, slide by slide. You can see on your left side.
Yeah.
Third slide is with marked. Maybe you can just go down. No.
And
try again with slideshow, maybe. Slideshow is on the right side, down. under the picture. Under the picture is a sign for slideshow.
Yeah, I used it, but I still don't see.
I don't know how to help you.
What about now? Do you see? Can you
No.
see the next one?
Maybe I can share your I don't know. Would you like me to share?
Yes, if you can. Yes, yes.
You have to stop, then I
Yeah. Yes, please.
share.
Mm-hmm.
But this is PDF, so we are here.
Mm-hmm. Yeah. Mm-hmm. Thank you.
Can you see?
Yeah, I can see. Yeah. Thank you. So the aim of my study was to identify the extent to which various groups of healthcare professionals involved in adverse events developed symptoms of distress and whether they were asking for psychological help. In countries with high healthcare efficiency like Sweden, Denmark, or Ireland, the problem of second victims has been studied and support programs for them have already been implemented. However, in countries with relatively low efficiency healthcare, mainly in Eastern Europe, the problem of second victims is not sufficiently studied. Hence, for this study, Croatia and Poland have been chosen, where such programs have not yet been implemented. The next slide, please. Mm-hmm. So in this study, the study is a cross-sectional study. It was conducted in 2022 and 2023 in University Hospital Center Zagreb in Croatia and Vojvod Children's Hospital in Poland. Special questionnaire was created for the purpose of this pilot study, and the questionnaires have been translated in national languages, printed and distributed among 250 doctors and nurses. It's above a quarter of all staff of the appropriate departments. What methods have been used for this study? The ANOVA with Bonferroni test has been applied to compare results of the questionnaires and compute the confidence differences between groups of medical staff regarding gender, age, profession, duration of work, and perception. The following null hypothesis has been tested. It's that all groups of medical staff perceive adverse events in the same way. The next one. And a few words about the results of the study. The hypothesis was disproved for every of the response options. Concerned with profession differences, the probability of the null hypothesis was very low. So this means that the differences are reliable, and the most notable differences over 2 times were recorded in the responses of the Department of Emergency and between Department of Emergency and Department of Psychiatry, as you can see on the slide. Few words about gender differences. Males, as accurate males, experience more mental distress after adverse events than females. Average scores show that among other distresses, male medical staff are most deeply feeling and in significant tiredness, low energy or problems with sleeping after adverse events. At the same time, females in such situations are most susceptible to feel excessive fears or worries. However, obtained scores of chi-squares and probabilities indicate the absence of significant differences in their perception of adverse events. And a few words about job position differences. As we found, nurses' perception of adverse events on all questions were significantly higher than doctor perceptions. This suggests that nurses are more susceptible to adverse events and experience various kinds of mental distresses after them more deeply than doctors. And main conclusion of this study is the problem of adverse event concerned every third Croatian health professional who is subject to one or another mental distress. The psychiatrist and microbiologist are the least painful when emergency, COVID, and orthopedic medical staff receives the adverse events most painful for mental health. Nurses are significantly more susceptible to adverse events and experience various kinds of mental distresses after them more deeply than doctors. And some kind of implications that can be after this study for hospital management. The hospital management should pay more attention to prepare medical staff for adverse events and strengthening their stress resistance through special training. First of all, they are needed by male medical staff who are not inclined to seek psychological help from specialists, boss or colleagues, nurses who are more difficult to tolerate adverse events than doctors, and frontline healthcare workers, including emergency, anesthesiology, and COVID department staff. Thank you for your attention. Take care.
Thank you, and take care. It's a nice message. Thank you very much. It's very interesting, and you present us very, very well. And I'm very sad that we haven't more time. Every of you have a very interesting topic, and this topic could be topic for more time and for more research. And we have a really very good pool for further action and for further researchers. Do we have a question now? I saw that stop share. So,
well, I think that Bohana, we are with the time over, but maybe
yes.
There is some time for one or two questions, no more. And perhaps one of the activities that you are conducting in your respective countries, maybe there is a common element, is how the people, it's easier for the people to understand the meaning of the second victims, because you are trying to support, to analyze the frequency, you are describing the symptoms or other things, so there are different perspectives. But indeed, when you are talking about second victim in your experience, the people, it's hard to understand the concept of second victims, or is easier to understand the concept? Are the people, the workers, familiar with the second victim phenomenon, or is the first time that they have heard about the second victims? What do you think about, what are your thoughts about this question?
This question for me or for Anatoly?
No, for any of the participants. Okay.
May I answer? it's a problem because I didn't interview them. I just surveyed them, so they filled questionnaire. But at the same time, I know that with help by Yana, we wrote this definition of what is exactly a second victim. Yes, and they had to read this definition before filling the questionnaire. So I guess everybody realized what is this when when they answered. But as results show it's only 1/3 of Croatian medical professional no experienced, said that he or she experienced this adverse events and had a problem, some kind of problem with mental health after that. So I guess this problem is not well known among medical staff in
Yes,
Eastern country. Maybe
I agree. Yes, yes.
Yeah, so
because
Bayana knows this better. Yes, she could
Yes, and it's the same in Slovakia
that
or
was
in
first
other
time.
countries?
Yes, same in Slovakia. Is it they know this definition, or you have to explain first?
I think that in the vocabulary, this term is missing. And also during our interviews, nobody was talking about their possible experience as I could be a second victim. You know, I would suffer from what is happening, and this is not my fault, kind of, you know. So nobody is taking it this way. They are saying it is a common human thing to make a mistake, but our superiors will not support us. We have to be in a fear of consequences. But nobody said, like really no one, that, you know, it may harm me. I can suffer from being involved in this. And we know that it is very often a systemic problem, not a problem of individual. Sometimes, yes, sometimes something happens that somebody really do not take care or something like that. But even though it is mostly systemic thing, so nobody should be blamed for it, but people just do not recognize it this way. They are very far away from thinking about themselves as they can feel something, as they can. Yeah. So that's it.
Yeah. Well, in our experience, people, I think that identify themselves as second victims, but of course, as you explained, I never used second victims before, and they don't know information about this phenomenon, but really identify the feelings, identify the emotions, identify shame and blame, and also identify that they need some support. But really, there are differences. That's clear. Okay. So, Bohana, I don't know if you have any other questions, so we are close to over this section.
I just would like to thank you all. It was really excellent and very interesting. And I need to say sorry for participants that we have some technical problems. So it is. So
okay, thank you so much for coordinating
it was
this.
Really excellent. Thank you.
This speaker corner, and of course, thank you to our researchers. Some of them have participated in the ERNST training school and in other studies in progress in our network. And I particularly want to say thank you for staying here to respond when we are asking you about what are you doing, to explain and to spread the word about the second victim phenomenon. So thank you so much. Well, we are over the time, but Maximiliano, please, if you can summarize the most important issues for today. Thank you so much, and we are
Thank you so much.
To close the session.
Thank you so much, Jose. Well, I will just use 1 minute. I prepared one slide just to summarize what we discussed today. So I will add a quick comment. only, okay, my screen, and here we go. Okay, so really quick today's summary. First, I want to congratulate with everybody because it was simply great. This half of the day, this afternoon was great. I learned a lot, and here I try to summarize what I learned and what are my possible comments for the day. First, from the first presentation, I was impressed by some words. For example, I really appreciate the concept of democracy with the right to be safe. So this was really impressive for me because, you know, all the time I'm thinking technically, but it's important. It's really important. It was really inspiring for me. And then also from the first presentation, also how it was practical, because there was the fighting fatigue together is something that is really practical, working together. So it is an idea that comes through working for legislation. That means to create standard that are able to explain the rights for the patient. This is the concept of democracy applied to the safety. And also, well, from this first presentation, I also was by the possible implication for second victim. The first one is the need for legislation, and also for the need of improvement of our leadership in this area. So the idea of working on the environment for professionals is something that is really important, and I think is possible to be applied also in also to second victim. So what I got was really a high-level presentation with practical ideas. Then I want to thank Professor Tella for how she was really able to respect the timing of the project, and I don't want to do any comment except the fact that thank you to everybody, because all the work packages are on the target. So I, at least, you know, I'm the president of the European Pathway Association. I like to think on the pathway perspective, and they say, well, we are at the end of our pathway. The ERNST is running to success, and from what I learned today from Susanna session, say that we are going in the right way. Then I really want to thank Professor Sushiro, because again, the no-fault system in Japan, his presentation was great. Was an impressive, successful case study. Well, quite different. I was trying to thinking about Italy. Maybe, you know, I'm Italian, so I tend to be one track when reasoning. But well, what I really appreciate was the approach about the key role of the patient, of the key role of the representative, the stakeholder, the key stakeholders. And this was really important. How we, in a continuously way, involved stakeholders through everything, well, from defining the compensation scheme, in the prevention, in the settlement, in the quality improvement process. Well, participation of stakeholders. This is a mantra. It's something that I want to keep in mind, and also for translating to second victim again, something that we have to keep in mind. So how to really involve stakeholders. And this is a really successful experience, and I think we learned a lot today from our Japanese colleagues. Then, well, my friend from Poland, it's again, I learned a lot. I'm a quantitative guy, you know, and an epidemiologist as a background, but the storytelling is incredible, how we can learn from storytelling. Again, I think it's time. Well, I cannot, maybe, I think it could be the time, and we have to discuss within our group that we try to be more active on collecting stories, because human beings learn from stories. This is something that always happens, and as care professionals, I think we have to work more on that. And maybe ERNST could be an incredible, powerful catalyzer for collecting stories, successful stories where we can learn and share with our colleagues. Last but not least, the speaker corners. Thank you so much, Mohana, for your leadership here. Thank you so much. Well, I cannot go into the detail of each presentation, but I think we had in the complex quite interesting, really interesting stories, different experience. The first one was a qualitative studies. Well, maybe not so many doctors involved, but really deep analysis, really important findings. Well, I think that we learned a lot about the possibilities. There is room for research, but for better understanding causes, responsibility, impact, reaction to adverse events. It's something that I really appreciate. I really appreciate the study. And when from Philip, the hospital team for psychological help, this is a practical approach, fantastic, but a really deep approach. Again, I want to do it in my place. I really appreciate. Thank you so much for your presentation, because I learned what I can do, what we can do today, and also for future possibilities. Because again, what I appreciate is the fact that you're thinking not for only for today, but also for tomorrow and the day after tomorrow. That's really important. Then, fantastic, from Serbia, awareness for second victim for social media. Wow, fantastic. I really like the word of social media. I'm not there, I'm not an expert, but really I appreciate it. New strategy, new opportunity, multidisciplinarity at the top, fantastic. Really, I appreciate. Again, from that we have to learn a lot. And then the last, the case study of medical staff, very concrete, very practical implication for today for staff, yes, but also for training. There's something that we have to need to keep in mind. So, my dear colleague and friends, I don't have any further comment. Please apologize me for my style, but I think we really
it's great.
And well, thank you for the participation, and see you tomorrow. But it's something that it was for you, Jose. I stop. Okay.
Thank you, Maximiliano. Thank you so much, Professor Paniela. I think it's a great summary for this great day. And well, I have learned many things. So thank you so much for all speakers. And tomorrow we meet again in this 4th International Forum. So thank you so much to all. And well, I see you soon tomorrow at the first time of the afternoon. We meet again. Thank you so much, and see you tomorrow.
Ciao. Ciao, ciao.
Hello. Bye bye.
Bye bye bye.
Bye bye.
Thank you.